Good evening, and thank you all for joining us for this webinar, which is part of a series of presentations that will be delivered on alcohol and other drug use funded by the Sydney North Primary Health Network. I'd like to begin by acknowledging the traditional custodians of the land and to pay my respects to the elders both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are on this webinar today. My name is Catherine Mills. I'm an Associate Professor and Director of Early Intervention and Treatment Research at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And I have the pleasure of facilitating this webinar, which will be co-presented by Dr. Lauren Gardner and Dr. May Sue. Dr. Lauren Gardner is a postdoctoral research fellow at the Matilda Centre, and her current research focuses on improving health and wellbeing through multiple health behaviour change. And Dr. May Sue is a specialist lead GP in the Masters of Psychiatric Medicine program for the Mental Health Portfolio at Hetty Higher Education. She is also an adjunct clinical senior lecturer in the School of Medicine at the University of Notre Dame and a GP and GP supervisor at Montrose Medical Practice in Glebe. And her specific interests are in paediatrics, women's health, mental health, and complex care. Just before we begin though, I'd like to draw your attention to the Q&A and chat buttons that we have on the screen. Please feel free to click on those and type in any comments or questions that you might have during the presentation. And we will also have some discussion during the presentation and time at the end where we'll go through these questions and comments. If you do wish to post a question or a comment, please remember to select the all panellists and attendees option so that everyone watching can see the questions and be involved in the discussion. We will also be enabling participants to verbally discuss with us aspects of the presentation at certain points, and we ask that all attendees remain muted until we open up that discussion, and you should receive a pop-up on your screen that asks you to unmute at that point if you would like to. If you experience any technical difficulties during the webinar, you can call the technical support line, the details of which are on the screen, or visit the Zoom support webpage and chat with one of the online staff members there. And I'll also put this information in the chat box so that you can find it if you need it at any point during the presentation. And we are recording the webinar, so if you'd like to view it again or download the slides as handouts, you can access them at the website on your screen, which we'll put up later as well. And lastly, please remember to complete your CPD assessment at the end of the webinar if you wish to. And I will now hand over to Dr. Lauren Gardner to start our presentation. Thanks, Lauren.
Great, thanks, Kath. Okay, so in today's webinar, we're going to be focusing on 3 learning outcomes, being to monitor and outline the interrelationship between alcohol and other drug use and physical health, to develop a comprehensive checklist to identify the physical health risks of AOD use, and to utilise course reference materials to identify and manage the physical health risks of AOD use, including awareness of and what to do next. So when we consider the rates of AOD use in Australia, in 2016, more than 3 in 4 Australians over the age of 14 had used alcohol in the past 12 months, making it the most commonly used drug across the country. Tobacco, the drug that causes more ill health and premature death than any other drug, was the second most commonly used, with 15% of people having used it in the past 12 months. And this was followed by cannabis, cocaine, ecstasy, methamphetamine, and heroin. Now, although the rates of illicit substance use may seem low compared to that of alcohol, when considered together, that's a total of 2.5 million people who had used an illegal drug in the past 12 months. And that's not including pharmaceuticals. When we consider substance use disorders, which according to the DSM-5 are a problematic pattern of using alcohol or another substance that results in clinically significant impairment or distress, within Australia, 1 in 20 people between the ages of 16 and 85 have a substance use disorder. Concerningly, a study investigating the link between substance use disorders and physical health found that within inpatient and outpatient units, 76% of individuals with drug or alcohol dependence experienced one other physical health condition, and 51% experienced 2 or more physical health conditions. So it's clear that physical comorbidity with substance use disorders is very common. However, it's also important to remember that many people drink or use substances at a high level, and they don't actually meet the criteria for a disorder, but they are still at risk of physical harm. In fact, within Australia, alcohol and other drug misuse contributes to 6.7% of all disease and injury, 6,660 deaths per year, and has a combined economic cost of $23 billion. So despite this evidence that substance use and physical health problems are common, there's been relatively little policy attention directed at addressing the physical health needs of people who use alcohol and other drugs. And those accessing services tend not to be adequately screened for their physical health. So it's really important that we consider that interrelationship between the two. And keep in mind that it can go both ways. So on the one hand, a person might present to you with a known history of substance use, leading clinicians to miss their underlying physical health conditions, such as attributing high blood pressure to the effects of stimulants. But on the other hand, a person may present because of a physical health issue. And if that's considered alone in isolation without further investigation and screening, their harmful substance use may be missed. Now, although this webinar is focusing on AOD and physical comorbidity, it must be recognised that mental health symptoms and disorders are also common among individuals who use alcohol and other drugs. And it's important to consider the interrelationship between all 3 factors. So there will be another webinar in this series that focuses specifically on mental comorbidity, so I won't go into it too much here, but it is really important to recognise. So for example, the comorbidity guidelines highlight that people with comorbid AOD and mental health conditions are at an increased risk of physical health problems, resulting in a need for interventions to focus on overall well-being. However, there has been some reluctance on the part of service providers to address multiple health behaviours due to the belief that making too many lifestyle changes will undermine a person's recovery from AOD use. However, this view is not sustained by evidence, and it's recommended that clinicians take a holistic healthcare approach. The guidelines recommend that clinicians address 4 primary behavioural risk factors, being physical inactivity, poor diet, poor sleep, and smoking. I've included the link to the comorbidity guidelines for you if you'd like to have a look at them to find out more. Although you can't directly click on it through these slides now, you will be able to do so when you download the handouts after the webinar. So now I'm going to hand over to May, who's going to take us through a few case studies.
So I'd really like us to have an interactive discussion about these cases. So if your computer has a microphone and you'd like to verbally respond, you can actually unmute yourself and be able to respond verbally. Please just mute yourself again when you're not talking. And if you don't have a microphone or you'd prefer to type your response, you can use the chat button, but please select to all panelists and attendees from the drop-down menu, because then we can have an open discussion and other people can see your responses. So I'll give you a moment just to have a look at that case study. For those of you who aren't able to view it, I'll just read it out for you. So this is actually a case of a gentleman who has presented to me. It's a 23-year-old man who was coming in with recurrent perianal abscesses and fistulas, but he also would come in quite regularly because he was getting constant episodes of acute chronic bronchitis. He had a background of being a smoker. When we discussed what else was going on with him, it actually turned out that he didn't drink very much alcohol, but he actually was using a lot of methamphetamines, ecstasy, and a significant amount of marijuana as well. He wasn't using any IV drugs. So I'd really love to hear from the audience. If this person was to present to you, what factors do you think would be the most important to address, and why do you think that they'd be the most important? I'm not really that scary. I'd love to hear some responses from the audience.
May, can I throw something in? I'm not sure if this is correct or not, but I'm wondering with the recurrent bronchitis, would you want, well, actually all of it, would you want more information about their substance use, more detail about sort of frequency, method of ingestion?
Yeah, so it sounds like you'd like to explore a little bit more about the frequency which is going on. So that might be one thing that you'd want to find out. Why would it be important?
Yes, I was thinking with the, anyone else feel free to chime in, but particularly around whether or not if there is the injecting drug use, whether or not where the injection is given, or sort of whether or not the person is using safe injecting practices might have an impact.
Sure. So in this particular circumstance, this person wasn't actually injecting. He was particularly memorable for me though, because one of the early conversations he had with me was he approached me one day and he said, with all seriousness, I've been thinking about injecting heroin. What are your thoughts on this? So if someone presented to you and asked you that, how would you respond? I think everyone's a little bit scared to respond about this case. So, just out of curiosity, has anyone else had any similar cases like this? Like, have they had anyone else who has come in with recurrent infections and they've had any other underlying sort of substance use? Or is this really unfamiliar? Okay. All right. Well,
I wonder, sorry mate, it's Katha, just jumping in, whether or not people are having any trouble unmuting themselves. If you are, please let us know by typing in the chat box, or if you wanted to add anything.
Okay. Great. I think we've got one comment that somebody's having IT problems, but we can see your chat. So if you'd like to share any comments that you'd like on chat, please feel free, and then I can read it out. So maybe if you also type to all panelists and attendees, then we can see what your comments are about this. So if you wanted to, if you're having difficulty unmuting, maybe if you could raise your hand. I think Anthony was saying that he'd like to make a comment. And let's see, Lauren, if you can unmute him.
Sure, I will. Okay, Anthony, I've just selected to unmute you, but I believe you will have a pop-up on your screen that has to accept it. There you go. Looks like you're unmuted now.
Yeah, I missed the part of it because the voice had gone off. That's why. What was the question or comment you said?
Sure. So if this person was to present to you, what factors do you think would be the most important to address and why?
His age, and also to the chronic recurrent bronchitis.
Yep. And why is it important?
The age or signs and symptoms?
Yeah. Why is that particularly relevant for this case?
Because you need to question how long he's been on these substances he's been taking.
Mm-hmm.
And also too about his smoking, and all these are comorbid factors which only will make matters worse.
Mm-hmm. So are you concerned that it might have a association with how likely he is to be able to stop the behaviours?
Yes, the psychosocial factors. Yes.
Right. That's a really helpful point, and thanks for being the first person to break the waters there, Anthony.
Yeah.
So I really appreciate that.
That's fine. Yeah, you have to work out why is he doing this. That's the key thing. Why is he taking all these substances?
And
yeah.
I think that's really important that you've raised that, because trying to understand what is the story, what's the underlying story behind why he's actually using it, can be really helpful in having further discussions with that. Why do you think that might help you?
Why? Perfect.
Okay.
The course, yeah.
I think you've just cut out for a moment.
I know, there's a problem with my laptop. I could type something, it would be easier.
Okay. Anthony, I really appreciate them. They're really important points, because what you're just trying to work out, and I think what you're actually saying is that the most important thing here is going to be for actually cessation of his substance use, and you're trying to establish why he might actually be using the substances and what might be some psychosocial and physiological factors which might actually be affecting his ability to stop this. Now, I've also had a comment from Nima Azizi, who'd also like to unmute as well.
Yep, so I've just clicked on unmute. So Nima, it should come up on your screen soon.
Thanks, Nima.
All right, so can you hear me?
Yep, we can hear you now.
Okay, good. So this case, I think 23-year-old with THC, ecstasy, and methamphetamines. I mean, first of all, you said why they do it. I mean, that's I've seen so much of this case. I mean, ecstasy, methamphetamine, they're both amphetamines, and using THC with amphetamines, that's very common at this age group. Now, here, I mean, asking for a specific reason, I mean, you say, I just enjoy it or something like that. I get more energy. And usually my patients with THC, they say we get more focus. But the thing here, I just recurrent perianal abscess and fistula with recurrent bronchitis. Now, I mean, perianal abscess, fistula, I mean, and these are two things comes up to me. First of all, if his immune system is compromised. And second thing is, with perianal abscess, fistula, is there an underlying gastric problem? But I can't get it. What's the relevance of using these substances with the current thing he has? I mean, recurrent bronchitis is smoking, yes, but perianal abscess and fistula, could there be other sexual, like orientation in this guy? Some I mean, it might be different. Some could be. So I think even the sexual history would be relevant in this guy.
Okay, sure. Look, I think what I'm hearing from you is that you're just trying to understand the link with how his substance use may be linked to.
Exactly. That's the question for me. It's a big question for me. Yeah.
It's a really good question, and I think Lauren's going to speak to that a little bit later, so we might have a further conversation about that. But I think I think the next question I'd really like you to ask is that answer is, I think Anthony gave a really good comment about what he thought would be really important for us to address. That it's really important to address the substance use. In this 23-year-old man, what do you think his agenda is for presentation? Why has he come in to see you?
Well, the recurrent infections.
So if his agenda is going to be the recurrent infections, and your agenda is going to be getting him to stop using substances, if his agenda and your agenda are a bit different, how might you manage that? I think we had two people who wanted to make some comments there. Was that Nima? Did you want to say something there?
Yes, I think. First of all, I think apart from the history we've done, I mean, these two matters. I mean, possibly at this session, we just get the history of drug use. The matter here now is the infection. Now we got to put some separate consultation in regards to the addiction. So I think it's not possible to completely address both of them in one session.
Yeah. Okay. All right. Yeah. So this is one of the. Meet my son. Yes. Look, I think it's one of the challenges that we often face in general practice is that when we've got someone who's presenting with something which seems to be unlinked, how do we have a conversation about that? I might actually start off with answering a little bit of Nima's question. Laura, maybe if we can go through some of the physical health things which can be associated with substance use, and then we might go back to how we might actually address this as well.
Yeah, sure. Okay, so have quite limited time here, so we're obviously not able to go through a physical health checklist that goes through every potential risk for every substance type. But we have pulled together some of the more common symptoms that patients might present with across the board, noting again that these may differ based on the class of drug and the mechanism of delivery. So firstly, in regards to the brain, you may see things like brain damage, stroke, insomnia, and of course we must mention the psychological health problems such as mental illness, emotional instability, and cognitive impairment. For the eyes, particularly when tobacco is used over the long term, you may see things like cataracts and macular degeneration. For drugs that are snorted, patients may have a damaged septum and nasal lining. For stimulants that cause jaw clenching and teeth grinding, dental problems are common. Cardiovascular issues may be present, such as hypertension, and if injecting, there may be things like collapsed veins and blood-borne viruses, such as Hep B and Hep C. Long-term smoking can lead to presentations of recurrent bronchitis and lung cancer. There may be kidney and liver failure, particularly with alcohol use disorders. Recurrent abscesses and skin sores may be present from injecting or picking at the skin. There may be inflammation of the stomach lining, reproductive issues such as infertility, and then just in regards to overall health problems, there were things like obesity, diabetes, malnutrition, and cancers, which can be quite common. So it's clear that there are a large number of physical health risks associated with AOD use. And so I guess now is probably a good time, May, to go through how we would manage this.
Thank you, Lauren. Look, I think, and just to comment as well, that we had a comment as well from Anthony, who also mentions that he agrees that one needs to address his sexual practice as well. Probably just going, oh, sorry, excuse me a moment. just one moment. I'm sorry, I've got a very excited boy here at the moment.
That's okay.
So one of the things that we recognise when we are looking at someone who's using substances. So just going back maybe to the slide that you were looking at before.
Sure, yep.
Is that some of these things seem often a little bit unconnected, but one of the challenges that you have when someone is intoxicated or they've been using lots of substances for a long period of time is that they may not always be looking after their general health care as well. And so part of that can mean that they are at risk of increased infections as well. So I certainly see your point that it may be really helpful to look at sexual health as well. Sometimes that may be not a direct cause, so it's not necessarily that they've had sexual practices which are unusual, which cause them to have an increased risk of abscesses in that area, but it may just be to general sort of nutrition and care that occurs which actually increases their risk at the time. So if we consider this and we consider that there might actually be some link to the physical complications that are actually going on to the alcohol and substance use, then how do we actually address having a conversation with someone? So if someone says to you, I've been thinking about injecting IV heroin, how might you have a conversation with someone about that? Well, it all seems a bit overwhelming really when we start to look at what are the things which might be going on and what they might actually be presenting with. And the checklist that we looked at probably did seem a bit overwhelming just even for us as well. It seems like there's a lot for GPs to consider and to manage. And what if the person presenting has a really different agenda from the general practitioner? So in 2013, the National Mental Health Commission described and supported a fundamental shift to an approach in mental health care within Australia. And what this actually describes is where recovery-orientated practice which empowers a person's capacity within their own recovery journey, so that they have a role to play within determination of what is important in and that gives value and meaning to their own lives. So I know this has been described within the mental health setting. I think it's also very applicable within the AOD setting. And it's really important to consider when there might be multiple health issues which are occurring, and especially when you've got differing agendas which seem to occur. And let's be really honest here, it's often the circumstances where not just the person presenting is in distress, but they're the ones which evoke lots of distress in the clinician themselves. So if in this circumstance you have a person presenting with recurrent infections in the context of AOD disorder and associated poor self-care during this time, they want the script for antibiotics for their abscess. How do you engage and approach the person about what might also be causing them to have distress? Has anyone ever heard of motivational interviewing? Is that new? So motivational interviewing, Lauren will discuss a bit more in the end about how you might also access some resources about this. And there will also be another webinar about this. So I wasn't really going to talk too much about this, but it can be a style of having a conversation with someone. And there's a lot of evidence that this is very useful in, particularly in the AOD setting. And what it actually is about resolving ambivalence. So if you have someone who is uncertain about a particular direction that they're going to have, and it might be that some of that discussion's in their own head, then it can be a really useful style of discussion which allows you to actually engage someone towards moving towards that stage of being. So if, for example, in this particular setting, you've got someone presenting who's got infections, they may not necessarily see the correlation between that and their substance use. And it's about, yes, Kath, you can ask a question.
No, sorry, you keep going first and just when you're finished.
No worries. Then what can be helpful for a general practitioner is to have provide some psychoeducation that it may actually be that the substance use may be linked to their physical symptoms, and then two, engaging them into conversation exactly as Anthony said as to why that they're actually using those substances and what value and meaning do they have in terms of their life and how that actually helps them along in their journey in terms of being consistent with their own values and direction that they want to be in. And sometimes having that conversation rather than necessarily telling them what to do can be a much more effective tool. Kath, did you have a question that you wanted to ask?
Yeah, I was just wondering, just in the last few sentences that you've mentioned, we talked about both substance use as well as use disorder.
Yeah.
I was wondering what your thoughts are about how important it is or whether it's important to be discerning one from the other and how you might do that in practice.
Yeah, it's a really good question because what you'll find is that it depends as well in terms of one, what people say can be very different when they say we don't use very much in terms of what the actual amounts are. And then in terms of the functionality that they have, depending, the effects on their functionality can be very varied as well. So I think determining that can also help engage them in the conversation as well. Having said that, sometimes when you're having the conversations in practice, I don't find that I always quantify it every single time because sometimes the conversations about the values and the meaning behind what they're doing can be just as important. And so sometimes they don't need to come to the decision in your rooms, but the fact that they're thinking about it and the fact that the conversations happening in their head is actually what affects the change. Does that
Makes complete sense? Yes, thank you.
Right. And I think that's part of, I guess, a really different way of thinking about how we do assessment, because one of the things when we do medical school is we're learnt to really quantify what are the things which are causing them to do harm, and that means determining exactly what are the amounts that people are doing, and sometimes it's just so apparent that there's a problem that in a certain way the amount's immaterial. It's actually about affecting the change, which is probably more effective. So it's determining which might be the most relevant at the time in that conversation. And the joy about general practice is we get to see people over time. So you don't have to feel like you have to do it all in that one consultation. Sometimes it's about just establishing that you can start to have those conversations, which is the important step. And then over time, you may have more and more steps about that same issue. So I thought we might move on to the second case study. So this is a woman in her 40s who's divorced with post-traumatic stress disorder from significant medical illness requiring intensive care and intubation. Now, she was actually in intensive care for actually over a month. So it was quite a significant illness that she had. And subsequent to this, developed alcohol abuse. She's also now morbidly obese and has fatty liver and hypercholesterolemia. So I think it's really useful here to draw the correlation that having significant physical illness can also predispose to alcohol and substance use disorder. And I wanted you to consider the same questions for discussion for this case. So if this person was going to present to you, what factors do you think would be the most important to address and why? What do you think her agenda may be for presentation? And if his and your agenda, her and your agenda were to be addressed with different, how might you manage this? And again, if you'd like some assistance with unmuting, if you could just raise your hand or put it in a chat, and we please let us know and we'll assist with that. because I think these sort of situations are often the ones which as general practitioners we really struggle with. So hopefully in this forum we actually have an opportunity to discuss how you might manage something like this. Okay. So maybe we'll move on to the next slide, Lauren, and then if anyone has any questions, please feel free to raise your hand, let us know. I thought this was a really important case to raise because trauma and AOD are really common comorbidities. And also situations like this can engender a lot of emotional distress for the clinician as well as the person presenting. The reason I've shown this slide, this is adapted from the international, it's the ITSS Expert Consensus Guidelines for Complex PTSD in Adults, which is very wordy, but basically it's the international guidelines for how to manage complex PTSD. So the way that I think about this is that when we see someone who presents in this way, often all we actually see is a manifested distress. And what that often means in this sort of situation is that maybe we're actually just seeing the alcohol use, or we're seeing the physical symptoms or the difficulty that they're having with engaging with physical care. So that's where you have the morbid obesity and the hypercholesterolemia and fatty liver, because it's difficult to actually be able to do some of the changes in lifestyle which we would associate as being helpful in terms of managing that. But what you need to also consider when you see someone who's got PTSD or complex PTSD is that the physiological effects of the trauma can mean that the person actually has difficulty managing their emotions and distress. So emotional lability, difficulty with emotional regulation. They may have reduced concentration or attention or memory, and plus some of those overt symptoms like we mentioned. And because of what that means when they have PTSD or complex PTSD is their ability to manage interpersonal distress and difficulty means that their relationships and supports can often be challenged as well. So that means that they may have reduced resources and resilience to cope with stressors which occur to them. So these difficulties can mean that when they present, they can be really unclear about what their own agenda is in the midst of the distress that they're experiencing. And the interactions within the consultation can make the doctor-patient relationship really challenging as well. It's also really important to be aware of the underlying vulnerabilities as to why the person would be, as to why a person would present in this way, because that also helps us feel there can be a lot of stigma when a person presents like this. Like often as clinicians, we may have our own distress and feelings, which might include anger, guilt, blame, and being aware of our own feelings in this can mean that one, we can probably put in more things to help manage our own distress, but also recognising that sometimes the reason that the person is presenting in this way is because some of the experiences that they've had. And what's really important to realise is that the way that they're presenting and those symptoms which are occurring are actually all treatable. So they can get better. Just like when we saw that checklist of physical health risks of AOD, you probably felt a bit overwhelmed. Now imagine if you're experiencing that and you're also unable to think through problems clearly due to maybe sleep deprivation, you're hyped up with caffeine, maybe you have a back injury. We recognise that we're often not at our best when multiple stressors occur and that these experiences can be really overwhelming. And that's often the experience for someone who is presenting with PTSD, complex trauma. And because this often happens hand in hand with OD, just to be mindful that those might be factors which might actually be occurring in someone who presents in this way. So when I see someone who presents in this way, the things which I think which are really important to consider is that you don't have to resolve every single problem in the first visit. Allow yourself and the person presenting time. That means that they can come in over multiple visits to finish the assessment. Assess what are the key issues which are occurring and prioritise, and using a recovery framework, it's best done in consultation with the person. If there are safety issues, then that's obviously going to take priority, but it's really important that even when you're addressing the safety issues, that you've still got some idea about what the agenda is for assessment in the back of your head. And distress management can be a really crucial part of care. So as many people presenting find this the most challenging aspect of care. So for AOD disorder, their use of substances is often a maladaptive coping mechanism for their distress. So therefore, part of reducing the use, so in this situation, in this case that we've discussed, to be the alcohol use, you often need to actually look at establishing increased supports for them, and sometimes you might need to even establish mechanisms for alleviating distress. They may already have some that they've used in the past, or some that they've already got but maybe haven't been turning to as often, and identifying that is part of the management process. So if we break it down then to each individual issue which is occurring, you know, if you look at that, it looks a bit overwhelming, but actually we have some guidelines about what we do for obesity and diabetes, and for IBS, and what to do if they've got lung issues, and for liver failure. So we know what to do. We know how to manage hypertension. If you look at each individual thing, it's not actually that overwhelming. It's when we see it all together and we've got alcohol or nicotine or methamphetamines or marijuana, that's when it actually seems overwhelming. So if you consider maybe just giving yourself a bit of time to identify what are actually the key processes which are occurring in this person at this part of time, including some of the, including very importantly, exactly as Anthony mentioned, the psychosocial factors which are leading them to be in this place and time. Well, then you have systems, then you have a assessment of what's actually going on, and then you can work out with discussion of after discussion with that person a timeline and a process for how to address each one at a time. Do I have any questions yet? So I ask you just to bear in mind, keep it person-centred, keep it recovery focused, and work together. And it'll make you feel less that you have to be responsible for all of it, and that they're not engaged, and that they're being non-compliant by not listening to you. Bear in mind that it can be really overwhelming, and it would be overwhelming for us to experience this. So understand what it can be like for them. And
Can I just make a comment, May, if that's all right?
Yeah, of course, Kat.
Just what you were saying there, just how it really rings true, what you were saying about, needing to potentially take multiple, different sessions or appointments to work through all of these issues. And it just brings to mind when we're doing research with these particular populations, that's the thing that comes up time and time again when we're asking people about their relationships with GPs and other health practitioners, is them saying how much they value their GP as someone who takes the time when so often, that they might present, but then they're very quickly sort of ushered away. Yeah, that was all.
It's a really good point, Kath, and I'm really glad you pointed out, because I think often what I often hear other general practitioners say to me in these sort of circumstances is that they feel a bit impotent, like they're just not sure what they can do, and that there's no role that they can play when there's all these things and comorbidities which are occurring. They're not even sure how to start. But I think what's really key there is it's the therapeutic relationship. Like, it's the fact that you're walking alongside them on that journey, that you're willing to listen to them and engage with them. And even if it doesn't always turn out perfect, because there will be stumbling steps along the way, that you'll be with them along that journey. Like, that's actually the critical part of the recovery process. Now, I have to say, just flipping that back a little bit, that if we are going to be a really important part of somebody's recovery journey, it's also really important for us to be mindful that we look after our own well-being throughout the process as well. So be aware of your own psychological distress. It might be really important for looking after yourself, but also recognising that when you're feeling very distressed in that consultation, that there might also be something going on with the person presenting that might require some further assessment and management as well. Have someone you can discuss complex cases with, and often in these sort of situations, a coordinated team approach works best. And sometimes in that, maybe you're the person who helps to organise that and be a focal point for the coordinated team approach. It's okay to point out inappropriate behaviours that are maladaptive as something to address. And just doing it in an open, non-judgmental manner can allow you to actually have a conversation about it and focus on a collaborative plan for how to address this. Because it's not that you're blaming them for having the behaviours, you're identifying that this might be, for example, look, I've noticed that you're turning up late for every consultation. I've noticed that it particularly comes up when we're starting to work on having conversations about your alcohol use. Look, is this something you're feeling really uncomfortable about? Why is that? And sometimes just putting it out there actually allows you to work on why that's an issue, so that you can actually troubleshoot them. And just as I've mentioned before, motivational interviewing can be a really powerful tool. And if you're not familiar with this, please come to the webinar in May, which will focus on motivational interviewing. So I'll now hand on to Lauren. But does anyone have any questions or comments? Otherwise, I'll leave it to you, Lauren.
Sure. So I'm just going to run through a few helpful resources that relate to what we've spoken about, and then we will have another opportunity to discuss any questions or comments. So if you do have any, then please do let us know. But as May discussed, it is often that dialogue between the GP and the consumer that is critical to effective treatment. So some key resources that might be useful are the RACGP article on motivational interviewing techniques for GPs. So this one outlines the theory behind motivational interviewing, the guiding principles, and how they can be implemented in practice. There's also the Motivational Interviewing Network of Trainers website, which links you to training, events, forums, and other key resources there that might be helpful. Also, as May touched on, we do need to be mindful of the stigma around AOD use. And we need to be aware that we may be using or inadvertently using language that is stigmatizing, and that reinforces negative stereotypes. So I've included a link to a resource called Language Matters, which provides information on using person-centered language and allowing that focus to be on the person and not their substance use. In regards to AOD resources that might be handy for you, there is the Drug and Alcohol Specialist Advisory Service you may be aware of. It's run through St Vincent's Hospital as an AOD consultancy for health professionals in New South Wales. So it's a 24-hour free telephone service that advises on the clinical management of consumers with alcohol and other drug-related problems. Then for the consumers, there is the Alcohol and Drug Information Service, which again is a 24-hour telephone service, and that provides information, referrals and counselling for the consumers. Some resources that also offer online services include Counselling Online, which has an online chat option for people concerned about their own or others' use. Specific to cannabis use, there is an interactive online program called Clear Your Vision. So that one helps young people to change their cannabis use. And then more specific to stimulant use, we have Cracks in the Ice, which was developed and is run by researchers here at the Matilda Centre. So that offers some resources for GPs as well as consumers, such as guidelines for GPs in managing acute presentations, psychostimulant use problems, and information and support lines that can be given to the individuals or their family and friends. And there is another 24-hour telephone service called the Stimulant Treatment Line, which provides education, referrals, crisis counselling, and support specifically around stimulus use. Then, in regards to resources focusing more on physical health and a healthy lifestyle, there is the holistic care framework within the comorbidity guidelines that I mentioned earlier. There's also an online program called Daybreak by Hello Sunday Morning, which can be accessed either via their website or an app. So this one aims to support individuals to cut back or take a break from using alcohol through an anonymous support community. It's free to join, and individuals participate in habit-changing experiments. So they replace alcohol with other healthier habits. They also get to have one-on-one chats with health coaches, and that one may be particularly useful for people who are living in remote areas or that have kids that are typically unable to attend face-to-face meetings regularly. I've also included a link to a fact sheet from Beyond Blue, which might be useful to give or to go through with patients, as it explores the interrelationship between sleep, exercise, and healthy eating, with some practical tips on how to improve on those factors. There is another fact sheet by the ADF, which discusses healthy eating during treatment for AOD use. So that one touches on how different drugs impact on a person's appetite and their eating. And it also incorporates recommendations from nutritionists about foods that can help in the later stages of withdrawal. So for example, they recommend that protein like lean meat and fish, complex carbs and vegetables can help to reduce cravings, whereas omega-3 foods like salmon and avocado are suggested to help avoid relapse. And then lastly, evidence suggests that food and activity diaries can help with motivation to eat healthy and be active. And this could be helpful for sleep as well. So I've included some links to templates for food, activity and sleep diaries there. And keeping track of these behaviours also provides an opportunity to set goals and measure improvements. And goal setting can also be a really useful motivational tool that could be used with your clients. So I've also included a resource to SMART goal setting, which you may have heard of. So that involves setting goals that are specific, measurable, achievable, realistic or relevant, and time-bound. So they could be useful to just work through as patients continue to present to you. And that's all the content that we have at tonight. So if you do have any questions or comments for May or myself after the webinar that you didn't get a chance to bring up, feel free to reach out to us on our email addresses there. And Kath?
Thank you, Lauren, and thank you, May. And because one of the exciting things for me as well about everything that you said is this focus. We so often fall into that pattern of if we fix the alcohol or other drug use, all the other things in life are going to fall into place for the person. But I think there's been growing research now to sort of show that it can actually be the other way around. And if we start to address some of those lifestyle factors, that could be a gateway into getting people to change their alcohol and other drug use as well.
Mm-hmm. Yeah, and it doesn't have to be one, then the other, then the next thing. Sometimes you're kind of looking at all of it at the same time.
Absolutely. I can't see any other questions that have come up over time, but as Lauren said, please feel free to email them through if you have any later, and that we will have the recording and handouts available for people to download shortly. Please don't forget about your CPD assessment if you'd like to complete it, and we hope to see you at future webinars. As May had mentioned, we have one on motivational interviewing that will be coming up in May, and another on the 10th of April that will be on new and emerging psychoactive substances. So thank you all very much, and thanks again to our presenters, and we'll see you at the next webinar.
Great. Thank you. Bye.
Thank you. Bye.